Hello, I'm Michelle Lavander, Director of the USC Center for Health Journalism. Thanks for joining us today, and welcome to our Health Matters webinar covering coronavirus, soaring child hunger, and unmet needs. First, before we get started, I want to acknowledge what so many of us are experiencing today. Our nation is reeling from the pain caused by the brutal killing of George Floyd and the systemic racism and injustice facing the Black community. As protests engulf our nation, the USC Center for Health Journalism stands in solidarity with Black journalists contending with the trauma of reporting on twin pandemics that disproportionately impact the Black community, COVID-19 and systemic racism. The Center for Health Journalism will continue to work to advance journalism that leads to a more just and equitable society, which takes us to our topic today. Communities of color and low-income families have been hardest hit by the economic aftershocks of the pandemic, which is why we want to encourage you, the participants in this webinar, to put a spotlight through journalism on child hunger and other unmet needs during the pandemic. And truly, we are experiencing a crisis of epic proportions, as you will learn today. The COVID-19 pandemic has ushered in soaring levels of child hunger among already economically precarious families. School cafeterias are shuttered, grocery stores offer far less in poor neighborhoods, unemployment is breaking records, and food bank lines are stretching for miles. Temporary renter protections for COVID are due to expire in many communities across the country, with the very real possibility of a wave of widespread family homelessness. Many families are so poor that they cannot afford food for the month, let alone diapers. In these circumstances, single mothers are experiencing high levels of anxiety and depression, and yet there are some promising models out there that offer some hope and some help. Here to help us explore these topics, we are joined by two distinguished speakers. Megan Sandel, MD, is an associate professor of pediatrics at the Boston University School of Medicine and an associate professor of environmental health at the Boston University School of Public Health. She's the co-director of the GROW Clinic at Boston Medical Center and the former pediatric medical director of Boston Healthcare for the Homeless Program. She's a nationally recognized expert on housing and child health. Previously, she also was the first medical director for the founding site for Medical Legal Partnerships, Medical Legal Partnership Boston. Dr. Megan Smith is an associate professor in the Department of Psychiatry and in the Child Study Center in the Yale School of Medicine and in the Department of Social and Behavioral Sciences in the Yale School of Public Health. Dr. Smith is the founder and director of the Mental Health Outreach for Mothers or MOMS Partnership, a community academic partnership to improve maternal mental health among low-income women through a community-driven, place-based approach. She's also the principal investigator of Elevate, a policy lab to elevate mental health and disrupt poverty. She is widely published on poverty, mental health, and gender. This webinar series is offered thanks to the Commonwealth Fund, the National Institute for Healthcare Management Foundation, and the California Endowment, as well as individual supporters like you. You could tweet about the webinar at the hashtag covering coronavirus. A word about our format today before we get started. We'll be hearing from our panelists first, and then we'll open it up to your questions. Because we have many people participating in the webinar, we'll ask you to write your questions in the control panel, and you can also share with us any technical difficulties you're experiencing there. We'll be archiving this webinar at centerforhealthjournalism.org. And now let's get underway and turn to Dr. Sandel.
Great. Thank you so much for having me today. I'm really excited to be able to talk about this really important topic that we're seeing. I think that in many ways, I'm going to talk about the intersection of hunger and housing and the COVID-19 pandemic and how really structural inequities are playing out on the bodies of children and their family. Kind of the roadmap of the talk today that I'm giving is going to be talking first just generally about the health and developmental effects of what's known about hunger, and particularly the intersection with toxic stress and experiences of discrimination, very much present and lifted up during the current trauma that we're dealing with around George Floyd's death, Breonna Taylor, Ahmaud Arbery, and others. I'm going to talk then generally about how hardships are tied to unstable housing and caregiver and child health adverse outcomes, and particularly talk about kind of the concept of homelessness and then the hidden homeless, and how there's a lot of concern about how many more people will become homeless in that ongoing potential tidal wave of evictions. I'll talk a little bit about how patient stories are able to show the multiple levels of how structural inequities operate, and then give a couple of ideas for stories and policy angles, particularly with a focus on working upstream and addressing equity. So let's get started. I think one of the reasons why we focus on hunger in children so profoundly is that many brain development that is happening in kids happens really in the youngest children. So within the first 1,000 days is where you're growing functionally the brain you're going to need for the rest of your life. And that vulnerable period even starts prenatally, but definitely through birth up through age 4. And what we see here is that there's the sensorineural pathways around vision and hearing and language and kind of major cognitive development. And that's both in terms of the synapse formation, how you're kind of tying things together, but also how you're pruning those networks. And so in many ways, as we think about who is the most vulnerable in our society, it really is young children. And what we know is that these young children predominantly live in low-income families, right? 40% of children live in a family that lives below 200% of the federal poverty limit, which is roughly around $40,000 to $50,000. And so as we think about that, these are millions of children that are potentially at risk because of the rising food insecurity. As we understand that, there is this concept of toxic stress and hunger in children. And I think it's really important to understand that stress in and of itself is not bad, right? Stress in these kind of brief kind of intervals can be actually positive, and that there sometimes can be small episodes where there's need for stress responses that can be tolerable. Where stress becomes really toxic is in prolonged activation of stress response, and especially when you have the absence of protective relationships to buffer that toxic stress is when you start to see really lifelong changes. There can be actually chromosomal changes and other things that happen. And I think particularly Dr. Smith's end of the discussion will talk a lot about how maternal mental health without being able to be that buffer becomes a huge issue. I'm featuring a couple of the reports that we have done at Children's Health Watch, which is a research policy network that I'm part of. And we have actually shown that being able to be food insecure in your first couple of years of life has huge changes in your human capital, reaching your goals in terms of being able to graduate from high school, graduate from college, and other pieces. And I think particularly experiences of discrimination, people who report ongoing experiences of discrimination have much higher rates of food insecurity. I think the other piece of why we believe that toxic stress and these household hardships matter is this idea of Maslow's hierarchy, that if you're spending all your time worried about your physiologic needs like food and water and warmth and rest, or you're worried about your safety needs, right? Do you have a home to go to? What is that neighborhood like? And I think we'll talk about place in more detail. That if you aren't able to have that foundation of physiologic and safety needs, you're never going to get high enough on the Maslow's hierarchy to your psychologic and self-fulfillment needs, your belonging, your intimate relationships, your esteem, your self-actualization. And so as we think about it, this is really about undermining the foundation of what is child and family health. So I'd like to talk a little bit about what we sometimes call is the home iceberg, because we spend a lot of our time talking about homelessness, and homelessness is kind of the part of the iceberg you can see. There's a lot of iceberg below the surface. And so as we think about it, there's a bunch of families that are actually housing unstable, that often have multiple moves or are falling behind on rent. One of the estimates from the National Low-Income Housing Coalition is, as we think about unaffordable housing and families falling behind on rent, they are estimating that 1.5 million families are at risk of becoming homeless because they are falling behind on rent. In April, 1 in 3 families were not able to pay their rent. And so as we think about that, that becomes a really important part of how are we going to prevent that and not see a cascade effect of people becoming homeless, not being able to go to school, parents losing jobs, and further causing that toxic stress and mental health implications. I wanted to share some research from pediatrics in 2018, where we published from our Children's Health Watch research interviews with over 22,000 families in 5 cities, in Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis. And we interviewed low-income renter families, and we found, this was pre-COVID pandemic, that over a third of them had at least one form of an adverse housing circumstance related to housing instability. Over a quarter of them reported falling behind on rent at some point in the year. 8% of them reported they had lived in at least 3 places in the past year, so implying that they had moved twice. And 12% of them either were currently homeless or they had had a period of homelessness in the child's young life. Of note, we interviewed families just in that critical brain window, that 0 to 4 time period. So these are families with young children, very vulnerable to these types of problems. And so each of these was associated with adverse health. I think what's important to note is these 3 forms of housing instability, the behind on rent group, the homeless at some point in the child's lifetime, and the multiple moves group, these were very distinct groups. So there wasn't very much overlap between them. The largest of the groups was behind on rent, but it was very much that these were distinct groups that needed to be identified and helped with different types of interventions. And then the other piece that I think is really striking is on this bar graph, you can see that people who are in the stable housing group had the least amount of child fair or poor health, or mothers being reported in fair or poor health, or maternal rates of depression. But what's interesting is when you look at the 3 different forms, right? The blue bar on the right-hand side is the homeless group, and you can see 50% increase in child fair or poor health, almost 100% increase in maternal fair or poor health, really 200% increase in rates of maternal depression risk. And then you can see 300% increased risk of food insecurity and making healthcare cost trade-offs. But I think what's really important to note is the behind on rent group, that purple bar, looks just as bad in most instances, and actually even worse in the food insecurity and healthcare cost trade-offs. And so as we think about the impending doom of people falling behind on rent during this pandemic, I think you're seeing that ripple effect, that it's not just about being homeless, even being behind on rent has that stress that's going to be associated with adverse health. I think the other piece to keep in mind is that housing is not a just your house. It's actually related to the neighborhoods. And so we know that many of the maps in most cities, this is actually a map of the city of Boston, shows that system level investment is really needed because you have deep rooted inequities tied to neighborhood. And so what you're seeing are 3 different maps. 2 of them are more honestly economic oriented, right? The percentage of people who are paying more than 30% of their take-home income towards rent and the unemployment rate are tied in the same neighborhoods that saw huge and elevated rates of COVID-19 infection. And so you see this cascade effect that these were neighborhoods that already were economically behind, needed to either stay at work with essential work, or were more likely to be laid off, and is more likely to be in overcrowded situations and or moving frequently, that is placing them more at risk for disease. And so being able to show that the place mattered is as important as telling an individual housing story into the neighborhoods. I think that as we think about how this maps to child health biologically, this is the same map of the city of Boston, but this time we're using actually an opportunity index that was developed by the Kirwan Institute at Ohio State. And we actually, these maps are available online anywhere across the country. You can go to diversitydatakids.org, pull up the map in your metropolitan area, and you can see that, again, the central city, as I go back to where the maps where there were a lot of elevated COVID infections and unemployment and difficulty paying rent, those are the same very light yellow areas that have low opportunity. They're more likely to have concentrated poverty, to not have higher performing schools, to not have as many daycare centers available. And what you can see is we actually pulled out of our electronic health record the blood pressure readings of 3-year-olds. And we actually mapped them on the larger the circle you're seeing is the higher the prevalence of elevated blood pressures in 3-year-olds, so above the 95th percentile for age in those children. And so that's where you start to say the social factors and the structures and the redlining history and other things are now playing out literally on the cortisol levels and the blood pressures and stress levels of 3-year-olds. And we published this in Academic Pediatrics in 2016. My colleague from Boston Medical Center, Dr. Renee Boynton-Jarrett, and her Vital Village network, because we needed to call on not just individual level intervention to lift children out of poverty, but neighborhood level interventions, the structural multi-level interventions, if we're going to be truly successful. As we think about it, I think I am not just a researcher, but I'm also a pediatrician. And so, as was shared in my intro, I'm the co-director with Dr. Sukaina Adolf at Boston Medical Center of a clinic we call the GROW Clinic for children. It's for children who are failure to thrive. These are kids that honestly are an inch off of the growth curve, below the growth curve that we normally expect. They're kids who meet the World Health Organization diagnosis for malnutrition, and they live in the city of Boston. And what my patients are reporting to me is extremely high levels of food insecurity, much higher than we normally see. We normally see somewhere between 20 to 30% of our families are reporting not having available food consistently throughout the month. That is now closer to 60% of our families are reporting real difficulty. And what is, I think, even more striking is we're able to, through generous donations to our hospital, be able to get families, certain types of gift certificates or other things to grocery stores. And I think what's striking is my families are reporting that they're having to go to 4 or 5 stores to get the milk that they need, or even worse, they need, say, a special type of milk, one that doesn't contain lactose, right? Lactate milk, because the child's allergic. They go to 4 or 5 different stores, can't find it. They finally buckle down, just get the regular milk. And then the child has diarrhea for a week afterwards because they are allergic to that milk, and they actually are now sick and losing weight even more. I had another family that reported that she was actually finally having her grandmother help her drive to the store, putting her grandmother at risk, the family at risk, because they needed to get the medically tailored meals that they needed in the foods that they weren't able to get. And so again, as you think about where grocery stores are well stocked and where grocery stores are not well stocked, that has huge implications, so that it's not just a story of food insecurity, but it's food insecurity in neighborhoods and structures that play out. I think that one of the things that we have to always acknowledge when we acknowledge social factors and how they drive health is that they're not isolated, they're interconnected. And also that they're not always negative. And so for many of my families, they've been able to stay more food insecure because of they're working with their churches or their spiritual centers, and they're being able to find ways in which to make sure that they are getting the food that they need or having different interactions. And I think that we have to always tell the story both from a structural change perspective, but also from a positive perspective as well. These are just 3 story ideas with policy implications that I would love to encourage people to look at. I think the first is the fact that eviction moratoriums are expiring as families fall further and further behind, and that becoming really essentially toxic stress in terms of families becoming homeless. I think there are some amazing federal solutions out there that were included, for instance, in the HEROES Act around funding emergency rental assistance to prevent eviction. $100 billion was being set aside for that. And the idea of putting together a nationwide eviction and foreclosure moratorium, given the fact that there's a very much a patchwork across the country. And I would ask you to look at the eviction lab at Princeton that is keeping those things up to date. I think one of the positive things is many cities are stepping forward with actual rent assistance funds while they're waiting for the federal government. In the city of Boston, for instance, they put aside $3 million for rent assistance. It should be of note that in a week's time, they got 5 times as many applications as they could actually serve during that time. The mayor just announced that he's putting another $5 million towards it, but this is really, I think, an important time where it can't just be a local solution. It has to be a state and a federal solution to move forward. I think it's also important to think about the economic crisis and how it's really disproportionately affecting people in immigrant families, families with young children who are making those daily trade-offs. And so while there was a one-time payment to many families, I think that it's really important that there are solutions out there to get families money more frequently and being able to do that. Particularly the Harris-Sanders-Markey bill is one that would give monthly payments ongoing to low and moderate income families, so they're not in this feast or famine where they get a one-time payment and then fall behind, one-time payment, fall behind, but has much better ways in which to prevent that toxic stress from accumulating. And then lastly, I think that food insecurity rates are soaring. And I think that we in Children's Health Watch published in the last Great Recession, when SNAP was increased, we actually saw food insecurity go down and actually child health improve. And so there are really important calls now to have SNAP benefits increased again to reflect the real cost of food, because as we're seeing with sometimes these grocery stores that are not well stocked, there's sometimes some price gouging. And I think that we need to suspend many of the harmful administrative rules that restrict access to SNAP, such as those that are punished for seasonal work and therefore fall off. For instance, in Massachusetts, in the Cape, that's where many summer people do jobs, and then that's where actually the highest rates of food insecurity in the state are because of these types of rules. I will just allude to the fact that there's some really amazing stories, and I think Dr. Smith will talk more about them, of now people doing these mobile deliveries to get to these neighborhoods. We in Boston have been partnering with the Fresh Truck, which delivers weekly installments of fresh fruits and vegetables to neighborhoods that often don't have it. I just encourage you that as we do this kind of concept of thinking about how social factors, I encourage you to go deeper beyond the typical stories to really talking about root causes and policy and structural changes. I think we spend a lot of time telling personal stories, and that hook is really essential, but I think we need to always talk about the structures and inequities that are there. It's not by accident that low-income kids of color, particularly Black and Hispanic kids and Latinx kids, have the highest rates of food insecurity. That's not by accident. And so are there ways in which we can tell stories where those communities are now coming together in new ways to try and make the solution? I think that we often now will talk about the equity angle is in every story. And I think sometimes it's really important not to talk about it from just equality, because as you see on the left-hand side of the screen, if people are at different heights, if the tall person, medium person, and short person all get treated equally, they have one box to stand on, then only the tall person gets to that apple of opportunity in the tree. It's when you treat people equitably, you give them what they need in order to be successful. You give the tall person one box, you give the medium person 2 boxes, you give the shorter person 3 boxes. They all get to that same fair shot. And I think that being able to acknowledge that people don't get to different heights by accident, it's through structural racism and oppression that kids that live in neighborhoods predominantly with less opportunities. And so being able to now design new policies that address those inequities, not just individually, but structurally, I think is where we need to go. So with that, I'm going to turn it back over and hear from Dr. Smith and stay around for questions. Thank you.
Thank you so much, Dr. Sandel. That was excellent. We're going to turn right now to Dr. Smith from Yale.
Wonderful. A pleasure to join all of you. It is not a technical glitch that you're not seeing me, but we had a bit of trouble with the webcam. So glad you can see the slides. And it's such a pleasure to, to follow Dr. Sandel's work and really her points around, universally acknowledging racial equity in this work and what I'll be presenting today as well. So particularly we'll be focusing on the mental health of families and specifically as it pertains to mothers and to children, starting with what we know about the impact of economic shocks. So events like recessions and events like we're currently experiencing with a high rate of unemployment related to COVID. I'll give you a specific example for some of our work that's focused on operationalizing poverty for parents. And particularly around this issue of diaper need and how that connects to maternal and child mental health. And then wanted to talk again, picking up on Dr. Sandel's point around, the stories of resilience. And so what do we know about fostering resilience, fostering strength, and not just focusing on a deficit-based perspective here, but what do we know about really fostering resilience in the time of economic scarcity for children? And really, I'll present to you that one of the ways we can do that is really by bolstering the capacities and the well-being of the adults who care for children. And then I'll end with some ideas for stories and policy implications. I just wanted to start by, grounding us in what we know about economic mobility for children, pre-COVID, is really that only 6% of children who are born into the lowest quintile households and economic and annual income, only 6% of those children reach the top quintile. And so 42% of children really born in poverty are going to remain in poverty. And we do know that, poverty is not just this experience of having less, but psychologically, what's described by even children and the adults who care for them is this feeling of poverty as, having really shame and anxiety and fear, fear of where your next meal is coming from, fear of where you're going to spend the next night, and really shame and stigma that's often associated with receiving benefits. And part of what occurs with those type of feelings of fear, of shame, of stress is that this, poverty does increase one's risk for psychological disorders. So in fact, families who live in poverty, adults and children, are 2.5 times more likely to be diagnosed with a psychiatric illness as compared to their higher income counterparts. And when we think about that, you might ask, what is really the causal relationship? That's an association, but we do know that there's strong evidence around causality. And particularly when we think about COVID, we know that from evidence with the 2008 recession, from other times, for example, in the US, where we've adjusted trade policies with China, and we've seen low-wage work disappear, there have been documented increases on depression, anxiety, and suicidality for parents, for adults who are caring for children. And those have been done, those studies have been done with longitudinal designs with repeated measures where we can really establish some degree of causality. And the question pertaining to today's webinar is also how that impacts child outcomes. We also have very well articulated data that describes when a parent's mental health really decreases, we know that this negatively impacts and has really pernicious, long-lasting impacts on child well-being. And the mechanism there is what I have in this box. Number one, economic shocks are increasing parental stress. Particularly, they're increasing something we refer to as cognitive load or allostatic load, which from a really sheer perspective of thinking about neuroscience and the structure and function of the brain, poverty and economic shocks associated with events like recession and unemployment really take up so much space in the brain that there's actually not room to maybe even think about, singing to your child, reading to your child, interacting with your child. And so it's this acknowledgement that most parents want to be good parents, that, that's what we hear over and over again, but that this environment of scarcity really takes up so much space that it makes those kind of activities difficult. And it makes decision-making and all the executive functions also challenging. So things like working memory become challenging. There's also something we know, a sociologist named Robert Putnam, who's written a book, most recently, Our Kids, has something he calls good night moon time, but it's really that scheduled time where parents have a routine of, for example, reading to their children at night. And what he talks about and what's been documented is really how that kind of scheduled time to read and to bond decreases when a family's income decreases. So, all of that is to say we can say that economic shocks, unemployment worsen a parent's mental health and a child's mental health. But we also know that there's interventions to improve the economic circumstances that actually boost mental health for parents, particularly mothers and children. So things like the earned income tax credit, things that Dr. Sandel referred to that would increase cash and increase wages for families, for example. And I wanted to turn to some of our own work where we've really thought about operationalizing poverty as it's specific to parents and children and mental health. And this quote at the top here is actually a quote from a mother who is receiving diapers at a diaper bank that I'm involved with, really talking about, in the context of COVID, the money that she would normally use to buy diapers for her 1-year-old, was really going at this point just to keep food on their table. So these choices that families are making around which basic needs they need to really meet, or if they can meet any of them. And so we've, along with our colleagues at the National Diaper Bank Network, have a definition of diaper need really being the inability to supply a sufficient amount of diapers to a baby or toddler to keep them clean, dry, and healthy. And it's important to note that programs like food stamps and WIC and cash assistance do not support the provision of diapers. And also a recent article in American Journal of Public Health by Kelly Massengale showed that really diaper banks are only meeting 4% of diaper need in the US, and this was actually pre-COVID. We know that the demands on diaper banks, which I'll talk about, have gone up astronomically since COVID. In our work, we actually found in a survey of hundreds of low-income women with children 3 and under in Connecticut that the #1 predictor of postpartum depressive symptoms, above and beyond housing insecurity, food insecurity, other social determinants of health, was actually diaper need. And that made sense in terms of what I talked about with this idea of cognitive load. But if you're worried about supplying diapers for your child, that really doesn't leave a lot of room for attachment and bonding, and doesn't allow for a feeling of self-efficacy and confidence, often in parenting. In other work, we've been documenting diaper need around the country, and we see it ranging from 27% in Kentucky, to 44% in Vermont, and 57% and upwards in Connecticut and New York City. We published some of our work on diaper need and depression in various journals, and under the Obama administration, the White House started a program to make diapers more accessible to low-income families through buying programs with nonprofits. And meanwhile, colleagues at the National Diaper Bank Network have also quantified really the economic impacts of diaper need on families' ability to go to work and go to school. So families who do not have a sufficient supply of diapers can't leave their children at childcare, for example, because you often need 2 weeks supply of diapers. So we've been continuing to quantify this impact, but really in the context of COVID, what's been out on social media and still I think really needs to be quantified empirically by researchers is this increased demand for diapers. So the DC Diaper Bank reported a 300% increase in demand in 10 days at the beginning of the COVID pandemic. And the National Diaper Bank Network, their link is there, has been continued to quantify this increased demand. So, along with diaper need adding to parental stress, there's also this idea of what we call social selection, but that parental stress and depression can in turn really lead families to downward mobility, and that as Dr. Sandel talked about, becomes a toxic stressor for children and child health outcomes. So, to put it simply, what we see in a lot of research using randomized trials is that depression does cause poverty through absenteeism from work, through lost productivity and employment, through other kind of chronic health conditions that can make it difficult for family members to work. again, the real positive and the glimmer for hope here is that we have effective interventions to treat depression and anxiety and trauma in mothers and in parents, and that these interventions, really phenomenal work by Myrna Weissman at Columbia and her work around maternal depression, these interventions actually have benefits. So when a mother's depressive symptoms are reduced, a child's depressive symptoms, symptoms of anxiety, symptoms of trauma are also reduced. So there's a lot of hope in this research. But I think when we think about resilience and what can buffer children in times of economic scarcity, in times of trauma and fear, it is these stress buffering relationships with adults and adults who care for children. Particular to COVID, I'm focusing on mothers specifically here and women, because we know that women are disproportionately burdened in terms of their risk for depression and anxiety, and actually particularly for women who are in the parenting years, that's when the risk for depression and anxiety disorders is the highest. And we know from COVID that about 60% of the jobs that have been lost were held by women, but also importantly held by women in low-wage work. So this intersectionality becomes definitely a cause for examining structural inequities, and also really a cause for policy solutions and action. We know that when we think particularly about maternal depression, there are just huge costs to society. Again, this is a recent report before COVID, but I also wanted to note that what's really critically important here is pregnant women. And we know that there's something called fetal programming, but that even increased stress and depressive symptoms prenatally, that the developing fetus is exposed to changes in hormone levels because of that stress and those depressive symptoms that can really change the structure and function of the developing brain. Also, one of my colleagues at Yale, Kimberly Yonkers, has documented that depression in pregnancy is more likely to lead to preterm birth compared to non-depressed mothers. And as I mentioned before, these long-term consequences for child behavioral and development are not transient, they're persistent. And I say all of that to be very careful that we don't want to in any way pathologize mothers, but just to say that we really have a robust literature now documenting these pernicious consequences. So, in terms of tying this together and thinking about, where do we go in terms of action and also potential stories of families at this time, I think one, it's really critical to name things, just as we're naming George Floyd and we're naming Black Lives Matter. It's really critical to name, things like diaper need or housing insecurity, and particularly to really name what poverty looks like for parents. And so, as I've talked to you about, we know diaper need increases parental stress. We know parental stress negatively impacts child outcomes. And so, why not think about, as we have conversations to support caregivers in the time of economic scarcity, why not integrate basic needs that are important to caregivers? So the state of California has wonderful guidance now for parents that focuses on how to relieve their stress, how to relieve their child's stress, but also in terms of integrating discussions on basic needs in those modules. So diaper banks have been moving. This is a picture of the Austin diaper bank on the right, where they're moving to drive-through diaper provision, where they're taking vans, and we're doing some of that work modeled on the great work at Boston Medical Center at Yale, where we have a van. My colleague Leslie Sood is doing a mobile van where she's distributing diapers along with pediatric screening visits. The other thing is that the impact on diaper banks has been tremendous, not only in terms of the increased demand, but decreased number of volunteers who are available due to their own illness or self-isolation. And diaper banks, like families, are being impacted by disruptions in the distribution and supply chains. Parents are talking, typically, we're hearing, as I alluded to, making choices between food and diapers. Also, parents are reporting increases in infants being irritable because they're sitting in soiled diapers for greater lengths of time. There is hashtag End Diaper Need, and the National Diaper Bank Network, again, is a great resource here. There's a bipartisan bill requesting emergency funding to support the provision and distribution of diapers to low-income families. There are also a number of municipalities that are providing diaper supplements to lower income families and connecting those to some employment related programs. But I think it's worth noting that there's bipartisan support for these kind of interventions. And the other piece I wanted to suggest to maybe delve further is, as I mentioned, I am the director of the Mental Health Outreach for Moms Partnership Program. And really what we've focused on, because of this intersectionality between poverty and between race and between economic outcomes, is how do we integrate mental health programs for mothers into poverty alleviation programs? And we've done this in a way that can be universal and ubiquitous, where we're providing cognitive behavioral therapy, which is one of the most efficacious treatments for maternal depression, in a group format over 8 weeks for 90 minutes a week in places like Stop and Shop and Shaw's supermarkets, in places like public libraries, and places like homeless shelters. And we're using these community hubs, and also a position we call a community mental health ambassador, which is a mother we train from the community who works alongside clinicians to provide the intervention. All of these services have moved to telehealth recently and are continuing to be delivered. And we're delivering them in partnership with government programs that are focused on poverty alleviation or focused on economic mobility for mothers. So the TANF program, Temporary Assistance for Needy Families, or cash assistance. So we're partnering with the DC Department of Human Services, where we've trained TANF staff to deliver mental health interventions for mothers receiving TANF. The same in the state of Vermont and their TANF program with the Department for Children and Families in Vermont. In Kentucky, working with mothers who are in probation and parole, and delivering mental health supports to mothers as they both are trying to achieve economic mobility for their families and reattach with children. And then we'll be launching work in New York City with the Department of Homeless Services for families who are in shelter. So just some ideas potentially to interview related to this work. This work is, as I said, ongoing switch to telehealth delivery. But what's been striking is we're really hearing from mothers about their own psychological resilience in this time. So how they've developed allies in the form of support from other mothers and the groups that they've been connected with, and how they're really focused on building assets, how they're focused on economic mobility. And this idea that our policy lab at Yale is really focused on, if we can improve mental health of families, we can improve hopefully economic and social mobility. There are tremendous government leaders, directors of TANF programs, directors of penal systems, directors of homeless services who are supporting this work and see the urgency of providing support and providing mental health care for mothers at this time, who I know would be extremely happy to speak about how they're integrating these programs, really embedding them structurally into poverty alleviation systems. And there are clinicians who are working on this program and community mental health ambassadors who are mothers who've graduated from the program, and one of the things we've seen as we've switched to telehealth delivery is the real importance of having this community mental health ambassador role. So having a mother from the community who can help families who may be living with 9 people in a 1-bedroom apartment. How does a mother carve out a space, a safe space, a private space to engage and discussions about managing her stress and managing emotions? And so if that means, going into a car or a bathroom, but community mental health ambassadors are really critical, serving a critical role right now in accessing mental health care. And finally, I just wanted to conclude with this idea about going back to diapers and really opportunity to think about embedding concepts of basic needs into how we pay for medical care for families and children. And so there's certainly precedent, and actually in that bullet point below in the Bundling Justice article, it references some of Dr. Sandel's work, but there's certainly precedent for Medicaid to pay for supportive housing, to pay for nursing homes, to pay for nutrition, and actually to pay for diapers for children with special health care needs and adults with incontinence. and of course, precedent to pay for mental health care. So prior to COVID and now during COVID, there's been some discussion about maternity bundles and pediatric bundles, which are payments that would be given to providers that include not only maternity care and pediatric care, but also supports, ancillary supports or very basic supports to things like diapers, housing assistance, enrollment, and WIC. And one idea, Dr. Sandel referenced the Kirwan Institute. The director, Derek Hamilton, is a stratification economist, and I gave you a link to one of his articles in the New Yorker article about his work, is ideas of baby bonds. But baby bonds are a way to really proposal to reduce the racial wealth gap and really to provide savings accounts to babies that are contributed to in an annual manner. To really increase assets for families, and we know that increasing assets would have tremendous benefits on mental health outcomes. So I thank you for that opportunity to share with you some of our thoughts and our stories today, and I'll turn it back over now to Michelle.
Thank you so much to both of you. These are just such informative presentations. We're opening up our discussion right now to all of you, and just a reminder that if you just go into your control panel, you can type in a question so that we can ask as many as we can of our panelists. We have one right now from Cheryl Weinstock, who asks, what are the best ways to sort of animate these stories about parental stress and to find the mothers who are experiencing it?
Great. Could you hear me? I'll start with that and definitely let Dr. Sandel add, but I know that one resources are certainly diaper banks, and the National Diaper Bank Network is a great place to start in terms of they're really a clearinghouse for diaper policy, and also many families who are advocates around this movement. So I would encourage you, either if you have a local diaper bank or working with the National Diaper Bank Network as well. And for the stories that I highlighted, you can also send me an email. I'm happy to put you in touch with some of our on-the-ground partners in the states we're working with who could also share their stories.
Yeah, I think similarly, we at Boston Medical Center have a Center for the Urban Child and Healthy Family, because we believe we really do need to develop what we're calling the pediatric practice of the future, one that integrates behavioral health into every pediatric visit and really does team-based care with parents as partners. So you're hearing a lot from Dr. Smith, particularly about this idea of people with lived experience being key members of the team. And so if you are interested, I'd be happy to connect you in with our Center for the Urban Child. We have many members of our family advisory board that I think could speak to that.
Thank you. One question that's come up is that there's been a release of a lot of inmates because of COVID, and we know that there's been more women who've been incarcerated. Are you finding that those numbers are significant enough that you're working with or hearing about women who are both newly released from prison or jail without really employment or anything, and also having to contend with these issues of family economic precariousness and feeding their kids?
You know, oh, sorry, go ahead, Megan Smith.
Thanks, Megan. So that, I was just going to comment on our work in Kentucky, where I think that's certainly been something we've witnessed. We've had mothers who are enrolled in our groups and our cohorts there who actually were now released. And so we've definitely seen it. We've definitely heard about the challenges, but also made a lot of effort to still include and connect with mothers where that's occurred. But Dr. Sandel, I'm wondering if you can comment as well.
Yeah, I think we've had some moms that have been involved in the criminal justice system. Another population we didn't mention that I think is really important is moms with substance use disorders and their substance exposed newborns. We're finding a ton of housing instability in that group particularly, and they also have really high rates of both maternal depression, trauma, and other things. We have I mentioned kind of this idea of pediatric practices of the future, and one of them is our SOFAR clinic, which integrates both maternal treatment for their substance use disorder with pediatric care, so doing kind of bi-generational care. And again, I think that's going to be the wave of the future for how we do this, because it's what mothers will do is they'll take care of their kid and they will not go to their own mental health appointments. And so the more that you make it a holistic part of care, the more that you break down those barriers and be able to set up systems for change.
We have a question from David Eggleston, who says, I value the strategies you both suggest. Is anyone also doing proactive work toward raising awareness of implicit biases that may greatly reduce popular or legislative support for the kinds of programs you're advocating for?
Yeah, it's an interesting point. We've started to think a lot about even just in simple language, we sometimes will refer to families as vulnerable, and it is a very kind of othering type of statement. And instead, I think that we have started to try to talk about marginalized families that oftentimes don't have the same opportunities. But I think either way, we are starting to think about policy arguments as being more universal, right? In order to be the parent that you need to be, if you remember kind of my Maslow's hierarchy slide, right? We have to be able to help people with their basic fundamental needs and their safety needs so that they then can get to be, I loved how Dr. Smith talked about the Robert Putnam kind of good moon time. I think that being able to help people understand that universality so it doesn't feel like us versus them is, I think, a really important point. I will just argue that on some level, we don't need more knowledge. Realize Dr. Smith and I are researchers, so we're not like, we really shouldn't say that because we spend our lives doing new knowledge, but it really is to me more about the strategic framing and how we honestly do the narrative change that many of you are really good at. And so the more to make sure stories feel more universal, but are told through that inequity lens, I think it will help us make it feel less like a handout and more like kind of a hand up.
And if I could just add to that, I think that was so well said. I just wanted to call attention, there's a group in terms of groups that really explicitly working on racial equity in this, Black Mamas Matter is a group that is incorporating race in this policy. And also, the Ascend Network at Aspen Institute is doing a lot around policy and incorporating a racial equity lens into that. So I just, highlight their work here. And also one of the ways we talk a lot about stress is, just stress is universal and being a parent is hard. And that in some ways helps to normalize it, in addition to what Dr. Sandel said.
And we have a question from Norman Nyazema, who asks how much, whether there's any data about whether there are more cases of postpartum depression due to COVID-19.
That's a good question. I'll just say briefly, I think it's too early. Let's be honest. It's our national estimates are not real time. So I do think that's something we're going to have to look at historically. I just want to note for the journalists. So having a baby during COVID-19 has been its own trauma, right? Because the people who are coming into the room have a face shield on and are wearing a mask and are wearing gloves and are trying to limit how much they're in the room. And for moms where we're doing universal screening, many of our sites are doing universal screening. If they're positive, we are now somewhat trying to talk with them about whether to take their baby and have their baby somewhere else or whether or not to go through the risks of having their baby with them. So just add all of that layering on. It would be surprising if you weren't depressed, right? Like let's not make this traumatic. This is really about just an actual situation that is traumatizing. I don't know, Dr. Smith, if you want to add anything. Yeah.
Sure, I was just going to add, I mean, again, what we know from the prior literature is absolutely that in times of, economic recession, we see rates of postpartum depression increase. I also just wanted to tie that back to the racial equity piece. And we know that, some of the studies that have looked at police violence and witnessing police violence and collective trauma associated with historical racism and violence, we do see that that's also something that's internalized by, certainly by postpartum women, and leads to increases in postpartum depression and trauma symptoms. I will say that in talking with a colleague who's a pediatrician who's working on the mobile van with newly postpartum mothers, one thing she was observing is that she can absolutely say that she's seeing, people who are fearful and scared and anxiety and have high levels of anxiety and depression. But when they're answering the questions on depression, she feels like they're just so grateful to be seeing someone, and they're so grateful to be getting care, and really so grateful to, and particularly with this van, to be served in their neighborhood. And so oftentimes that their responses are not being reflected in how they're answering those questions on depression. So I think it's too early, but also wanted to make that caveat that probably some qualitative research is really needed there.
Yeah, I will just name, we didn't talk about it in depth, but the maternal mortality differences for Black mothers and white mothers in many parts of the countries mimic third world countries. So they're in this kind of concept of postpartum depression. Again, I think those are the same neighborhoods and parts of the country that are having higher rates of COVID-19 as well.
And Sherry Lynn Perkins asked, why has the diaper need doubled or increased so much?
Well, I think, for sure around the distribution, that Dr. Sandel talked about with food too, as occurred with diapers, but that there's just a huge supply difficulty in families purchasing diapers now. Stores are out of diapers, and the diaper banks are having that same problem. But certainly as people's incomes are declining because of loss of employment, with a family member, a sole caregiver, that's putting increased strain on family income. And so that, families are making choices to put food on the table and not be able to provide diapers, for example.
And what do we know about building resilience and in a moment like this, where everyone is so isolated, you've talked about some interventions like the bundles and the food, mobile food, and of course we saw the kind of sobering picture of the lines to get diapers. But are there other ideas about helping women in these crisis, kind of sustained crisis, to have more resilience that are actionable right now?
It's kind of interesting. I don't know if people saw Dr. Mona Hanna-Attisha, who is the pediatrician from Flint, Michigan, that uncovered a lot of the lead in water. She wrote an op-ed in the New York Times about not asking kids and families to be resilient, but asking for places to become resilient, because let's be honest, 6 years later, Flint still doesn't have clean water. And so I do think this idea of resilience is a bit of a double-edged sword as you think about covering it. I think that what Dr. Smith really eloquently talked about was this kind of child development is about serve and return, right? This idea of, do you have the bandwidth as a mother to be able and not be depressed, and to be able to do that reading and that really good child stimulation that's there. And that is very buffering for kids who are dealing with stress and other things. And so sometimes we'll say the best way to help kids is to help their parents be able to do that, and that builds resilience. That being said, again, I'm going to ask for, if you talk about building resilience, you can't talk about it just individually. You have to talk about what are the ways in which we invest in neighborhoods to make sure that people have jobs that they can go to, that they have childcare centers, that they have the diapers to send the kids to the childcare centers, because each of those chains in the link, if you weaken one of them, you break the chain. And I think that as long as we talk about as much resilient places, and the fact that we're uncovering these deep-seated inequities, again, redlining in the 1930s, if you haven't seen kind of Color of Law and Segregated by Design and all that stuff, we're just paying the dividends back of all of that racism in terms of what is playing out on the bodies of our kids. And so, yes, we need to build more resiliency in terms of mother-child interaction and addressing depression, but we also have to remove a lot of the pressures that are there that are causing those problems in the first place.
And we have a final question, which is a little bit about telemedicine and a little bit about the peer mental health mentoring that came up, and also touching upon your idea, Dr. Sandel, about neighborhoods and resilience, because getting to a mental health appointment for some women might be really quite challenging and involve, transportation issues that take really a long time to get to a major medical institution from your neighborhood. And so is there a kind of positive benefit here where we're seeing that this expansion of the telemedicine and the phone call, even if the client is, hiding in their car or the bathroom, to have a private call? I mean, is that suggested some new ideas for both of you and others working in this space?
Yeah, I meant to, sorry, go ahead, Dr. Smith.
No, go ahead, Megan.
So I was going to say, I forgot to mention it. So I do think telehealth is one of the positive silver linings of COVID. For many years, we were trying to set it up, and it was, a lot of regulatory barriers. And literally by removing those regulatory barriers, we at Boston Medical Center set up our telehealth system in 48 hours. And I'll say that our normal no-show rate for behavioral health is somewhere between 40 to 50%. And it's now with telehealth less than 10%. And so this is about access. And I do think telehealth does give really unique access to be able to do therapy in ways that are going to be much more resilient and much more positive for families.
And I would just add to that and agree with all of that. We've not 48 hours, but we've been probably in like a week to 2 weeks with our telehealth. But I think particularly for mental health, there's a piece that I do want to really amplify, which is the importance of a position like a community health worker or community mental health ambassador from a mental health perspective with telehealth, because we know that even in without telehealth, many mothers are fearful of receiving mental health care because they're fearful their children might be removed from their custody. And so telehealth actually, in some ways, while it breaks down barriers, could also potentially increase stigma or fear. And so that role of a community mental health ambassador, community health worker to help with some of those concerns and really make telemental health culturally relevant and equivalent is important.
Well, with that, I want to thank both our two excellent presenters and our audience, and thank them for their wonderful questions. This webinar series is offered thanks to the Commonwealth Fund, the National Institute for Healthcare Management Foundation, and the California Endowment, as well as individual participants like you. And so please feel free to help us support this work. We've expanded our webinar series to be weekly from just 8 or 10 times a year. And you will shortly be receiving an email that has a survey that asks you about your feedback on this webinar, as well as your suggestions for future ones. We encourage you to take a moment to fill it out. And we will be archiving this webinar at centerforhealthjournalism.org. Thank you again to Dr. Megan Sandel and Dr. Megan Smith, and thank you to all of you. I hope your day is productive and healthy.
Thank you.